Yeah, I'm Martin Punter. So I work here with Tina. I'm a neurologist and stroke physician, and Dr. Herwadkar is a neuro-radiologist. So in some ways we sort of do the same job. We look at the brain and spine and nerves, but my job, I suppose, is to look at it from the outside, and Dr. Herwadkar's job is to get direct pictures of it. And we both have an interest particularly in blood vessels, so that's the stroke physician part of my job. And I guess most people will hopefully know the sort of what cervical cephalic means, but just to make sure that everyone's understanding. So cervical is generally neck and cephalic is head. So I'm going to give just a very brief overview of cervical cephalic FMD, and I'll talk very briefly about asymptomatic presentations, which really is predominantly patients who are found by screening. So let's say FMD is found in the kidneys, and then with the screening process you'll find effects on the blood vessels in the head and the neck. And then symptomatic, and we'll talk a bit about the sort of symptoms that patients sometimes experience, and I think highlight some of the perhaps more important or more urgent symptoms, and what sort of things we can do about that. And then Dr. Herwadkar will go through some of the imaging that we generally request in patients. So as Tina highlighted previously, FMD was predominantly thought to affect the kidneys, but I think more and more with increased screening and increased recognition, we see more and more patients who have blood vessels involved outside the renal blood vessels or kidney blood vessels. So up to 65% of patients are said to have extracranial cerebrovascular disease. So extracranial means really the neck and below, and cranial is from the skull base here and up. So what I'll just show you here is this is a drawing, of course, from Gray's Anatomy, I think, originally. And you see here the common carotid artery, which is the main blood vessel that goes up to supply the front of the head and the brain. This becomes the internal carotid artery, which supplies the vast majority of the circulation of the brain. And then the external carotid artery, which predominantly supplies blood vessels outside and the head and the scalp. And then you have the vertebral artery, which supplies the back of the brain. So that supplies the area of the brain called the cerebellum, and then the occipital lobes, which we already saw with Bean's presentation. So FMD commonly affects both carotid arteries and also vertebral arteries as well. So you can get effects here at the front and here at the back, and we'll see how that can present in terms of patient symptoms. The external carotid artery is said to be affected less commonly. So as I've mentioned, how would you find asymptomatic disease? Well, asymptomatic by definition means you don't have symptoms. So predominantly, and that's true for all sorts of conditions, you find that by screening. And so you'd be looking in patients who you think it's appropriate, or patients probably who have already been found to have kidney FMD, to look at the blood vessels. So CT angiography, that's what CTA stands for. MR angiography, that's MR is magnetic resonance, and all carotid Dopplers. So CT angiography and MR angiography are probably the best ways of looking at it. So sometimes it's not very good presenting a single image, but if you can imagine that picture we just saw, what you see here, because there's contrast in the blood vessels, you can see this bright line here, which is the common carotid artery, and then you see what then becomes the internal carotid artery. Now, because it's a bit wavy, you only see bits of it because we've got a single slice here through a picture. But that's what a CT scan looks like. So bones are dense, and everything less dense than bones is grayer until you get to black, which is air. Then MR angiography. Again, this is a different technique. So MR scanning doesn't involve radiation, but you can also see the blood vessels through various techniques, and generally it's probably better to be using contrast to looking at these sections of blood vessels. But you can again see the common carotid arteries, and then the internal carotid arteries, and then the external carotid artery and the vertebral arteries. So again, it looks a bit like that drawing that we saw. So those are both very good ways of looking at the blood vessels in the neck. And then carotid Doppler ultrasound. So that's an ultrasound technique. So again, that doesn't involve radiation. But the views can be a bit more restricted. So because of trying to get the probe up to this sort of level at the jaw, you can only go a certain height up on the carotid arteries. But the benefit is you can get more of a dynamic function of the blood vessels. You can look at the actual velocity of the blood and whether there's turbulence in the blood flow. So each of the techniques have their own benefits. I'll move on to symptomatic cervical cephalic FMD. So the symptoms really can be divided into non-specific symptoms and then what are probably quite specific symptoms. So headache is rather a non-specific symptom. There are many causes of headache, and headache is said to occur in about 50% of patients with FMD. The difficulty with headache, of course, headache is a really common complaint anyway, and particularly migraine. So there are, patients with FMD will also suffer from what might be considered a standard migraine or other headaches, but nonetheless it's probably more common. And then tinnitus is often mentioned, and in particular pulsatile tinnitus. And when we think of pulsatile tinnitus, that means a sort of a whooshing tinnitus rather than a standard, a constant tone. That's quite suggestive in the textbooks, that's quite suggestive of blood vessel disease of some sort. And then neck pain, of course, neck pain is also very common. But neck pain, particularly sudden severe onset neck pain, is one of the sort of cardinal features of carotid artery dissection, which is what I'll talk about next. So cervical artery dissection refers to all the cervical arteries, so all the arteries in the neck, and that is said to occur in up to 10 to 25% of patients with FMD. And the main problems in terms of the results of dissection are the risk of stroke, and then there are non-ischemic causes. So when you get a stroke from a cervical artery dissection, normally what happens is the artery dissects, so blood goes between the layers of the artery, because there are multiple layers in an artery normally. That creates turbulence, which then acts as a focus for blood to clot on the rough areas of the lining. Then those little blood clots can break off, or big blood clots, and go up to the brain and cause ischemia and then cause a stroke. But of course, patients with FMD have a very high risk of hypertension as well, which is its own independent risk factor, both for dissection, in fact, but also for causing stroke due to long-standing damage to small blood vessels in the brain. So there are other reasons why patients may have a stroke, but certainly in the setting of neck pain, dissection is one of the things we often think about. So just again to explain that slide, so that I've mentioned there TIA as well. So if you're not familiar with that, TIA is short for transient ischemic attack. So that's what some people call a mini stroke, a term I don't really like, but it usually in the textbooks again will say that's a stroke that resolves within 24 hours. So strictly speaking, you shouldn't have any brain damage with a TIA, and often if patients have symptoms that resolve within 24 hours, when you scan them, there will be some evidence of damage. But that's to differentiate from a stroke, which is longer lasting symptoms. And then there are non-ischemic problems resulting from dissections. We've talked about pain. Patients will often have hemicranial pain, so that's half your head hurting on the same side as a dissection, or headache, and also cranial artery palsies. So there's a picture there of someone's tongue. I don't know if I could persuade you that the tongue is leaning off to the left side. So if you've had a dissection on that side, that's one of the effects that you could see is one or two of the cranial nerves, which are the nerves supplying various parts of the head and neck, can become weak on that side as well. The muscles become weak because of the nerve damage. And then the other feature you can see as part of the blood vessel wall abnormalities is intracranial aneurysms. So you can have an aneurysm as a result of the dissection, but this is specifically looking at the intracranial circulation. So that's the circulation inside the head, so after the blood vessels have gone through the skull base. And those typically would either again be found asymptomatically, so through screening processes, or can be found as a result of rupture of the aneurysm, and that would classically cause something called a subarachnoid hemorrhage. That's a very severe sudden onset headache, sometimes termed a thunderclap headache, and that's usually quite a clear presentation for many patients. And I think most doctors would be aware of the thunderclap headache and what that might mean, even if they don't get as far as thinking of fibromuscular dysplasia. Aneurysms can also more rarely cause ischemic strokes and TIAs as well. So we'll move on to Dr. Herwadkar now. He'll go through a bit more of the sort of things we look for on the scans.
The affection of this internal carotid artery and have consequences on the functioning of the brain, some of which Martin said resulting in stroke, resulting in tinnitus or dissection. And the typical appearance that is described in the textbook is this what we call as concertina appearance, and we have seen lots of examples today, and these areas of what we call as outpouchings, bumps on the artery, if you like, with arteries in between them where it artery becomes narrow. And perhaps one point I can share with you is that what we are studying here, what we are looking here is the inside of the artery. This artery is the vertebral artery, and again you can see these undulations on it, and what we are seeing is the inside of the artery. Tina showed a beautiful slide very earlier on in her talk where we showed a histology. And what histology shows is actually the wall of the artery. Yes, we know what the lumen inside looks like, but the problem is not here. The problem is in the wall, which we don't know. And the wall of the artery, the wall of the pipe is abnormal. And because it is weak, or because there is a disease within it, this blood inside it then starts to bulge out. Okay, so the problem is not just this concertina appearance, it lies within the wall of the artery. And And this is something Tina and we want to try and take it further along with Martin to try and study the vessel wall if we can, because that's where the interest is, that's where the problem arises. Dr. Siripurupu, my colleague here, she's got a very heavy interest in what we call as vessel wall imaging to try and ascertain, and this we do in the insides of the blood vessels for other conditions. But it would be very interesting to see, I think, Tina, to see whether we can apply this for this condition over here. A few examples just to go further on from here. We have heard the term dissection. Okay, we have heard it quite often today, dissection. What is dissection? Dissection is when blood which is normally flowing along a straight path suddenly goes along an aberrant path and it finds a channel where it should not go through. So normally our blood is flowing within the tube itself, within that artery, and when the wall of that artery becomes diseased for whatever reason, if it's weakened, then blood will try and dissect out of the normal channel into the wall of the artery. And this is what I'm trying to show over here on this picture, just over here, okay? If you concentrate on this picture, this is a section taken through the base of the brain over here. Won't really complicate much issues over here, but the blood vessels are seen as black areas. I hope you can, we call this imaging of the brain vessels, but I think this is imagining. Perhaps if you can imagine these black areas which are the blood vessels, and you can see this area over here, this bright area, and that is actually blood which has gone out of the normal channel. And you would ask, what does that mean if it dissects, what does it do? What it does is, once the blood has gone out of the blood vessel, it collapses the channel through which it normally goes. And if it collapses that channel, it's going to reduce the blood going to that organ, be it the kidney or in this case the brain. If that blood supply is reduced, it is going to have the effects. In minor cases, if that blood vessel is near the ear, it can cause this whooshing noises, the tinnitus, because the blood is now going through a very small channel and it can become turbulent, and that turbulence creates that whooshing noises. This is a different patient. This is what we call as an MR angiogram, where we don't have to inject anything inside through the groin route. We can just place anyone in the magnet, in the MR scanner, and we can obtain some pictures. And this is just a way we look at these pictures. This is called as, again, that same common carotid over here. This is the internal carotid artery which goes through the brain. This is that external carotid which supplies the neck vessels structures. And you can see this nice smooth caliber of the blood vessel over here. But as we come over here, this artery suddenly becomes loopy. We have heard of this term loopiness or tortuosity. That's one of the features that we see associated with FMD, this loopiness, and people have actually tried to characterize that. In this case, it is what we call as a S shape to it. Sometimes there can be C shaped, different shapes to it. Not only that, what we see is this artery is not quite right. There are areas of undulation on it with areas of narrowing, and this is what we are seeing. The effect of that dissection, the artery should be in there, is now looks very, very corrugated, if you like, and this is another way of just depicting that. So this is dissection, and what Martin very clearly said earlier on is, wherever there is this dissection, this irregularity, the blood doesn't like that. It tries to repair it, and when it repairs it, it forms clots on its surface to try and repair it. Those clots in the initial stages are very fragile, and they can break off, and they break off and they can go inside and they can lodge inside the blood vessels in the brain, and that affects to stroke because it is cutting off that part of the blood supply to the brain. And this is just an example of that. Again, I want to emphasize this is not common that we see, but once we see something like this, we try and understand for ourselves why has this occurred. When we see someone with stroke in the young individual who does not have the traditional risk factors, we try and study the blood vessels, what has caused the stroke. And then Tina, Martin, they would come and ask me, Amit, do you think this patient could have FMD? So here, again, I don't really want to go into too much details. This is the hindbrain over here, just at the back. Normally, this structure is gray, but we can see that it is quite bright over here, and this is what we call as a cerebellar stroke would look like. And this is just another MR scan to look at the blood vessel. So this is called as an MR angiogram. You can do various things with an MR scan. You can get an MR scan of the brain just to highlight what the brain looks like. But you can take out the brain and look only at the blood vessels. So this is looking only at the blood vessels. We looked at some examples of the carotid artery. These are the vertebral arteries. These are two arteries at the back which climb up the neck and join at the base of the brain at the back to form this what you call as a basilar artery. And this is what it looks like normally over here. And you can see up here in this individual over here, there are areas of narrowing and out pouches, somewhat we describe as sausage type appearance. So this is an area of dissection. And again, we have to remember this appearance reflects that there is a problem within the wall of this artery. The blood, instead of going in this normal channel, has actually dissected out of it into the wall of the artery, giving rise to this appearance. And when it was being repaired, there were clots which were formed, which went distally and lodged into some of these blood vessels going to the brain. So this is what a dissection looks like, and this is what its effect would be on that individual. And just finally, I think the last condition we talked about was an aneurysm. Okay, aneurysms can form anywhere in the body. And what is an aneurysm? It is a focal bulge within an artery. Okay, and again, it is a manifestation of problem within the wall of the artery. So normally the artery is nice and straight. This is one of the arteries of the back part of the brain, and this is what the dye flows nice and smooth. And these are the branches. So this is your M60, this is A576, and then A34, and what have you. And this is how it supplies the rest of the brain. And these arteries are nice and smooth over here. In this individual over here, you can see this is that artery again coming up, and this is that same artery which will go further on. And you can see this is a normal branch coming here, and this artery, instead of being of normal caliber like this, suddenly it's tapered. Not only is it tapered, there is that focal bulge on its surface, and this bulge over here is called as an aneurysm, and it is a weak point. And because it is a weak point, especially inside the head, there is a possibility that it can give way. And when it gives way, it can cause the blood which is there inside can spill out, and when it spills out, we call it as a brain hemorrhage. And this is a very specific pattern of brain hemorrhage called as subarachnoid hemorrhage. It's just a space called as a subarachnoid space during where it can occur. This is not at all common, but if it does occur, it can be life-threatening and needs to be treated as an urgency. So this is what an aneurysm would look like, and in this person who's got dissection of this long part of this specific artery. I think I'll hand over to Martin. Thank you.
So just very briefly talk about treatment then. Now we've looked at presentation and imaging and diagnosis. So we'll look at the treatment of headache, which really is best to think about in terms of acute and prophylaxis. So some patients will be troubled by headache periodically. So let's say they have a bad headache a month, something like that. And with those patients, normally you'd recommend treating with aspirin, paracetamol, and going up the pain ladders. So that is to say, increasingly powerful painkillers, and also anti-sickness drugs for some patients. And that's something that most people have experienced a headache from time to time. Then we can talk about prophylaxis. So in patients who are particularly troubled by the headache, so sometimes if they're very severe, even if they're relatively infrequent, but most typically if they're very frequent headaches, and so probably 2 or 3 disabling headaches per month, then you'd look at prophylaxis. So we've got various classes of drugs which you can give to patients to take every day, regardless of how bad the head is. And that's to help keep control of the headache. And most of the evidence for those sort of treatments is in treatment of migraine. And a lot of the headaches in patients with FMD do have a migraine sort of phenotype. That means that they're a bit like migraine. And we use drugs such as some of the older antidepressants, we use drugs such as some of the epilepsy drugs, and we use some of the beta blockers for treatment of migraine would be the standard treatments. The next sort of, I think, important aspect of treatment is to look at treatment of stroke. And I think this is really important generally in terms of public health, but also in terms of FMD. So you can look at primary prevention. And so primary prevention of stroke really is management of cardiovascular risk factors in the general population. So management of hypertension, which we've seen is a particular problem with FMD, and also, which is I think really important and worth stressing time and time again, every clinic appointment, every health contact, but smoking cessation. I cannot stress how important that is also for reduction of stroke risk. I think another important thing is to talk about avoidance of potential triggers. So in patients where there's known to be a weakness of blood blood vessel walls for whatever reason, whether there's been a previous dissection without any particular evidence of any reason, but also in patients who you know might be at risk of dissection, to avoid potential triggers. So the sort of things you'd certainly want patients to try. Then I think where I was sort of particularly interested in then is treatment of the hyperacute stroke syndromes. So I think most people probably were aware of the FAST campaign. So this was a very successful public health campaign in the UK with the face, arm and speech and time test, where I can't remember when it was first out, probably in about 2004. And then again a few years later, and I think it's been out a third time, and that's really to bring to the fore stroke symptoms, recognition of stroke symptoms for the public as well as for staff, healthcare staff in the communities and paramedics. And I think the FAST campaign probably was one of the biggest drivers for the success we're seeing with treatment of hyperacute stroke, because if people don't recognise stroke symptoms, it doesn't matter how good you make your acute stroke services, people aren't going to present to stroke services. I think it's very important to be aware of stroke symptoms, because that is one of the complications that can result of FMD, and to seek early advice. So quite often, in fact almost always, in the stroke services, we're certainly at the time of presentation, we're probably not necessarily aware. I'm not aware of a patient who's ever turned up saying they have FMD to our hyperacute stroke services, and we have thousands of patients a year coming. That's probably, at least in part, because we probably don't ask. Because as Dr. Herwadkar says, it's not necessarily that in the forefront of people's minds when you're working in A&E, and it's probably something that should be. But these little bottles here are what we often have available to give to patients who present very early in their stroke. So as I said, recognition of stroke is really important to get to hospital early to access the right treatments. So this is what's called TPA or alteplase, which is the clot-busting drug that many people may be familiar with. And that's the drug we can use to break up clots in ischemic stroke and hopefully restore the circulation and hopefully resolve the symptoms. So that certainly would be something of benefit to patients, and there's not any reason in patients with FMD why that drug shouldn't be given either. Then the other thing that's become, or becoming, I use that term rather hesitantly, becoming more available across the UK is clot retrieval. So that's where, using radiological procedure, you actually try and mechanically disrupt the clot. So this is something that's only really acquired the necessary evidence to be seen as a very useful treatment in the last 3 or 4 years. And it's something that NHS England are actively working at the moment to try and get that as widespread as possible. But that again, if you see, these are very small pictures, sorry, but if you see here this artery, which is the middle cerebral artery, which again is a branch of the internal carotid, is blocked. You can see that red arrow. And after clot retrieval, the artery is open again. So again, that's another way, a very effective way of restoring circulation to the part of the brain that potentially could get damaged. And if that's done early enough, there are very good outcomes, not always, but there are very good outcomes generally for the patient population presenting with these large blood vessel occlusions. And again, there's not any real reason why patients with FMD shouldn't undergo those procedures, although I suspect, Dr. Herwadkar may have a view, you'd perhaps be a little more anxious because of the potential for damage to the blood vessel, damage and already potentially weakened blood vessel in that patient group. Then for patients who have had a stroke, then we would be speaking about secondary prevention. So how would you prevent another stroke, another perhaps more damaging stroke, or another TIA? And that is largely as for primary prevention. So you certainly want to be aggressive about management of blood pressure, aggressive about trying to promote smoking cessation. Certainly patients who have had a stroke should then be treated with the relevant antithrombotic drug, whether that be antiplatelets such as aspirin or clopidogrel, or anticoagulants, drugs such as warfarin, which thin the blood in a different way. And there are different reasons for using that, one of which may be cervical artery dissection. So effectively, they're as effective as each other for most patients with cervical artery dissection. And also, just because someone has FMD, I think it is also important to be conscious that there may still be other reasons why patients may have had a stroke. I've mentioned about the blood pressure in and of itself being a risk factor for stroke. Of course, making sure you test patients for diabetes, it may or may not be appropriate to look at heart imaging, but certainly most patients should have prolonged heart monitors who have had a stroke, because diseases do coexist, and so common conditions can still occur in patients who have rare conditions. So just a very brief summary really. So cervical cephalic disease can be a part of FMD. It can be asymptomatic or symptomatic, and just to highlight, for patients who do have what are sometimes termed fast symptoms, so any face, arm, speech problems that come on very suddenly, it's important to be aware and important to seek help early. And then the approach to treatment is broadly similar to patients who've had a stroke. The approach to treatment for patients with stroke is broadly similar to patients whether or not they have FMD. Thank you very much.